Sabah khair. Thank you very much for inviting me today. Lecture اسمها What's New in Sudden Cardiac Death Risk Stratification, and it's based on the 2022 European guidelines. I'll talk about a short introduction, risk stratification in patients with coronary artery disease, patients with dilated cardiomyopathy, patients with other cardiomyopathy, and primary electrical abnormalities. Sudden cardiac death is a sudden unexpected death after a non-cardiac cause has been ruled out after investigations. If you want to classify them, we have sudden unexpected deaths. In 40% of cases, a non-cardiac cause can be found, and if not, that's a sudden cardiac death. Sudden cardiac death, if we go for an autopsy, if there is structural abnormalities, structural heart disease, myocarditis, or coronary artery disease, and if no cause is found, it's a sudden arrhythmic death, and the primary electrical abnormalities, or maybe we will not find any cause. The cause of sudden cardiac death varies depending on the individual age. In young patients below the age of 35, there is predominance of genetic disease like primary electrical disease, cardiomyopathies, and myocarditis. In those above the age of 35, most cases or half the cases are related to coronary artery disease, especially acute coronary syndrome. And in older patients, we have chronic structural disease predominate, mainly due to acquired disease like coronary artery disease, valvular, or heart failure. Our message for guidelines was structural heart disease is a major risk factor for sudden cardiac death. And we can see that from this algorithm for evaluation of patients presenting with an incidental finding of non-sustained VT. كان أهم حاجة في الالجوريزم دوت is exclusion of structural heart disease through a 12-lead ECG, an echocardiogram, exclusion of coronary artery disease, and a CMR. These are the most important investigations to do for patients for exclusion of structural heart disease. In patients with coronary artery disease, left LV ejection fraction has been the cornerstone for decision-making for long-term primary prevention of ICD after myocardial infarction. However, ejection fraction has major limitations. One, the majority of sudden cardiac death cases occur in patients with normal or mildly reduced ejection fraction. Few patients with reduced ejection fraction will benefit from the ICD, and a reduced ejection fraction is a risk factor for both sudden and non-sudden death. What does the guideline say? One thing, we will do an echo for the patients to evaluate the ejection fraction 6 to 12 weeks after an acute myocardial infarction. If the ejection fraction is severely depressed below 35 and the patient has heart failure symptoms, or the ejection fraction is below 30, even in the absence of heart failure symptoms, these patients need an ICD. What about patients who have a depressed ejection fraction, but it is not severely impaired in the 36 to 40%? The ejection fraction is not enough for ICD implantation. So these patients, if they have symptoms or a non-sustained VT during monitoring, will go for an EP study for programmed electrical stimulation. If they have a sustained monomorphic VT inducible, these patients will implant an ICD. If not, they just need a follow-up. What about patients, secondary prevention patients, patients who already had sustained monomorphic VT? If it is the first presentation, it depends on the ejection fraction again. If it is below 40, they will go for an ICD implantation, and that is a class 1 recommendation. However, if it is higher than 40% and it was hemodynamically tolerated, we have 3 options, and all of them have the same class of 2A in the guidelines, and that is catheter ablation, which is a preferred method in these patients, or an ICD implantation, or amiodarone. Patients who already have an ICD, if they have an ICD, we will see if they are on amiodarone, we will go for catheter ablation. If they are not, we can still go for a catheter ablation or add amiodarone. The second group of patients with structural heart disease are patients with dilated cardiomyopathy and hypokinetic non-dilated cardiomyopathy. In the past decades, ejection fraction has been the main pillar for decision making. However, ICD did not improve survival in the Danish study, and these results might be explained by the low arrhythmic risk of the study population due to updated heart failure treatment and high compliance. The second explanation is that dilated cardiomyopathy is a heterogeneous entity in which each disease has a different sudden cardiac death risk. Genetic variants account for about 50%, and dilated cardiomyopathy can result from myocarditis, exposure of drugs, toxins, systemic endocrine or autoimmune disease. So we cannot treat all these categories as one entity. So there are two emerging methods for risk stratification of these patients other than the ejection fraction. One of them is the CMR and late gadolinium enhancement for detection of myocardial fibrosis, which is present in about 30 to 40% of cases. And meta-analysis combining almost 3,000 patients showed that late gadolinium enhancement was associated with a 5-fold higher risk of sudden cardiac death, and this was also present in patients with an ejection fraction higher than 35%. The second thing after CMR is genetic testing. Why? Because some genotypes require a specific approach, like the patients who have a lemon A mutation, which is present in 8% of idiopathic cardiomyopathy. Because these patients have a poor prognosis, they have early development of conduction disturbance, atrial fibrillation, and ventricular arrhythmias. What do the guidelines say? Unlike the patients with coronary artery disease, where the algorithm starts by the ejection fraction, here it starts with a CMR. And the reason for that is we can detect a reason for heart failure other than an idiopathic dilated cardiomyopathy like myocarditis, and that can be managed in a separate algorithm. The second step will be a family history of dilated cardiomyopathy or sudden cardiac death, or the presence of AV block before the age of 50 years, because all of this suggests a genetic, would direct us to do a genetic testing. If we detect a pathogenic mutation of the lemon A, these patients, they have a dedicated calculator for risk assessment. If the 5-year risk is more than 10%, even the ejection fraction is mildly impaired below 50%, they have non-sustained VT or AV conduction delay, these patients can implant an ICD. So we do not need a severely impaired ejection fraction for implantation of ICD in these patients. Now, what about other patients? We have patients who have severely depressed ejection fraction below 35%. They are indicated for an ICD, but now it is a class 2A, and that's a downgrade from the previous guidelines where it was a class 1 indication. However, if the patient have an ejection fraction that is mildly impaired between 36 and 50%, and they have 2 or more of the risk factors on the right side of the screen, which are syncope, sustained monomorphic VT on programmed electrical stimulation, and gene mutation, or late gadolinium enhancement on the MRI, these patients can go directly for an ICD implantation, although still their ejection fraction is not severely impaired. Patients with hypertrophic cardiomyopathy, there is no big change. Still, we have the calculator that includes 7 variables: age, the LV wall thickness, left atrial size, LVOT gradient, family history of sudden cardiac death, non-sustained VT or unexplained syncope. And this classifies the patient into a low category that can be reassured, intermediate category, and the high category that should implant an ICD. Other risk markers are not included in the calculators. I will not go through them, but these markers are valuable for patients who are at the intermediate risk. Mitral valve prolapse generally has a good long-term prognosis. However, there is a subset of patients who are at risk of ventricular arrhythmia and sudden cardiac death. The risk factors are syncope, non-sustained VT, presence of mitral annular disjunction, late gadolinium enhancement, reduced ejection fraction, and T-wave inversions in the infralateral ECG leads. I will talk about 2 primary electrical abnormalities, long QT syndrome and CPVT. Patients who have long QT syndrome, we have three categories of patients. The patients who had aborted cardiac death, or who had syncope and did not receive a medical treatment before, or patients who have resting QT prolongation with or without a genetic mutation. All these patients should undergo the general recommendations to avoid medications and treatment of electrolyte disturbance. They should take a beta blocker, and that's also a non-selective beta blocker like propranolol or nadolol. And patients with long QT3, they will benefit from mixellitine. Patients with aborted cardiac death will get an ICD because it's a class 1 recommendation. The other patients will get an ICD if they are still symptomatic after medical therapy. I will not discuss the CPVT because it has already been discussed in the previous session. Like in short, beta blockers, plus or minus flecainide, and ICD implantation in patients who had aborted cardiac arrest. What are the future directions? Because still our methods are crude in detection of patients who are at risk of sudden cardiac death, especially that most of the patients will not have a structural heart disease. So artificial intelligence and machine learning for prediction of near-term events through analysis of certain patterns, clinical variables like the age, race, gender, the socioeconomic standard, dynamic ECG monitors like the portable devices, imaging modalities for detection of ejection fraction or myocardial scar and fibrosis by MRI, and serum biomarkers for inflammation or biomarkers of cardiac injury. My take-home message is the presence of structural heart disease is a major risk factor for sudden cardiac death. EF remains a pillar for indication to implant an ICD in patients with coronary artery disease. There is an increasing role for cardiac imaging, especially CMR, as well as clinical variables for diagnosis and risk assessment in patients with dilated cardiomyopathy. Genetic testing is indicated for diagnosis and risk assessment of dilated cardiomyopathy and primary electrical abnormalities. And thank you.